what I am going to talk about is something that's often, what I think is really important, but it seems to have often been ignored in the discussion of exposure and thinking about people and thinking about your risk. And I think it's really key for all of us to try to get this concept across, because it informs everything you do in terms of thinking about your risk, as well as deciding how to protect yourself in whatever setting, home, restaurant, exercise facility, work, etc. And this concept is pretty straightforward, and it applies to the exposure in terms of any hazardous contaminant in the air. It's basically that your exposure or your risk is a function of two variables: concentration and time. And I've used these, actually I developed these figures well before the pandemic. And I published them first in a commentary on the CIDRAP website, and then eventually they are in at least one paper. But the purpose was to show people, what happens over time. And the other figures that you've seen from other scientists and engineers are similar, but what this is showing is sort of the time feature that is often neglected when we talk about, but everyone understands that there is a concentration feature to this, but it's the time piece that seems to be not shown. And in the first figure, and this is just showing, excuse me, a cough or a sneeze. So a single emission of particles. But if you think about this as ongoing in terms of talking, then it continues. Over time, you continue to produce lots of particles, mostly smaller ones when you're talking. Over time, and assuming no ventilation in this case, the larger particles are going to evaporate and settle onto surfaces, and the smaller ones are going to disperse throughout the space. So this person nearby in the beginning might experience some droplet propulsion. You have to be very close and facing somebody for that to be even likely. More likely, though, is that you will inhale those particles. With time, standing close by, yes, the concentration is higher, but as you can see, as time goes on, particles disperse. They disperse through diffusion, and if there is ventilation, they can disperse by air current, by the movement of air in the space. Since people generate lots of mostly smaller particles during breathing and talking, so this concentration is going to continue to increase over time. And this, Dr. Jimenez mentioned, they're small particles that take a long time to settle onto surfaces. And it's minutes, many minutes to hours. So even if a source leaves, somebody infected leaves the room, having spent time there, those particles can remain for a considerable amount of time. You notice that I will talk about aerosol transmission, and I want to just highlight why I say aerosol transmission. The word airborne has a very specific meaning to the hospital infection control and prevention folks. They think of things in two buckets, droplet and airborne. And airborne has this definition, and always has had this definition, that it means inhalation, but only in very long distances away. When we take that word and use it to describe what we mean, which is inhalation anywhere, we aren't really getting our message across. So I'm trying very hard to avoid the use of either droplet or airborne when I talk about transmission. And I focus on aerosols, which is really what they are. Any particles suspended in air or in a gaseous medium is an aerosol. And what's encompassed in this is primarily inhalation. As Stefan noted, I am going to talk, at least one of us will talk about the hierarchy of controls and industrial hygienist. That is one of our areas of focus areas. I've found it useful to talk about the hierarchy in a somewhat different way than typically it is presented, which is from the context of infectious disease, there are sources, people generally. Pathway, then the source is the thing that generates the particles, the infectious particles. There is a pathway or a travel the particles travel through the air and reach the receptor. So where we are trying to intervene is in three places: at the source, at the pathway point, or at the receptor. And the best and most effective place to intervene is at the source. And what I'm, again, trying to emphasize is there are ways to think about the exposure and intervening at the source in the context of concentration as well as time. If you eliminate sources, meaning say you test ahead of time and people are positive and you say, nope, you can't be here, that by extension ensures that you decrease the concentration. If you basically tell people they can only be in a space for a short period of time, not knowing whether they're infectious or not, you've minimized the amount of time that there can be exposure as well as that there can be emission. Pathway controls are generally ventilation, which is mostly what this expo is talking about. And I've listed a few things which all have been mentioned. You can increase the building ventilation and clean the recirculated air. You can use local exhaust ventilation to collect particles, and you can prevent air movement from source to receptors, which nobody really has talked about here. But this is the purpose of like an airborne isolation room at a hospital, is to prevent air movement from a room where there's an infectious person to the rest of the hospital. And the issue is the lower the airflow means the longer time it takes for particles to actually remove themselves or be removed from a space. Receptor controls are basically personal protective equipment, and I focus largely on respirators because I know how well they work and I know how well other things don't work. But you can think of them as both in the context of concentration as well as time. And of course, the hierarchy says, and control banding would point in this direction as well, do the source and pathway controls first, and receptor controls only come after you've implemented as many of the source and pathway controls. I'm not going to spend a lot of time on this, but we don't really know what the infectious dose of SARS-CoV-2 is, but I will tell you it has to be low. And that would explain absolutely, in addition to the fact that there's aerosol transmission and inhalation, that it doesn't take very many viruses or virions for somebody to be infected. So we know a little bit about this from one hamster study, which suggested a very low dose of 5 virions by aerosol, and a human exposure study, which was done in England by nasal instillation, which suggested an 50% infectious dose of 10 virions. Again, these are very, very low infectious doses. An individual particle that somebody generates, through talking, breathing, whatever, will contain multiple virions. So it doesn't take very many of those particles. I'm not going to go through this in any detail. You can look at it later. And I thank Dr. Raymond Tellier from McGill University for helping me with this list. But there are many aerosol transmissible pathogens. And these are not just issues in healthcare, they are issues in workplaces and many other settings, schools, et cetera. There's a long list of human-to-human transmission ones. So, and some of them are common, like human influenza A. And lastly, I just want to talk briefly about my favorite topic, which is respirators versus masks. This is a very good study by Bill Lindsley at NIOSH, where he did a nice comparison of how much inward and outward leakage do you get for different kinds of things you put on your face. And the respirators, the lower the number in terms of leakage, inward or outward, the better. So respirators, as you can see, are very low, have very little outward or inward leakage and very good filter efficiency. On the other hand, as you move down the list towards the face coverings, especially the cloth masks, you start to see how much leakage there really is inward and outward in terms of and that has to do with both their very poor filter efficiency as well as generally their poor fit. And it doesn't matter how well something fits if it has bad filter efficiency. And maybe some of you have seen this, but I wanted to emphasize this or explain this table. And this table is really a time table. It isn't a concentration table. And a lot of people sort of, assumed that what I was talking about was both of those, that I'm somehow suggesting that this is like a risk assessment or a dose response model or something. It's not any of those things. What I was simply trying to do was demonstrate the difference in amount of time it would take you to get an infectious dose if you start with the assumption of a 15-minute period of time, which is what CDC used for its contact tracing period. Anybody who had more than 15 minutes was assumed to have been exposed. Anybody less was not. Well, there's no science, of course, that underlies that assumption. That was made for, feasibility and efficacy. But it was a good starting point because it helped me illustrate what happens if the source is wearing something, the receiver is wearing something, or both are wearing something. And what you note is as you move from a cloth mask, a surgical mask, to a fit-tested filtering facepiece respirator or a non-fit tested filtering facepiece respirator, you move from minutes to hours. But you also need to consider the fact that the source and the receptor have to be wearing something for it to really make a big difference. So if you're wearing, for example, as a receiver, a non-fit tested respirator, which many of us did, those of us who understood about aerosol transmission, and everyone else around you is wearing nothing, you really don't, you only get about an hour. So you still can't spend a huge amount of time. And that isn't enough time in a workplace by any means, which is why both people need to be wearing something good. And the worker in particular needs to be wearing a fit-tested filtering facepiece respirator. So that's the end of what I want to say. I just wanted to really emphasize that it's important, sorry, I'm going to stop sharing, that we think about both particle concentration and time when you're in a space, and that you think about your intervention, whatever interventions you're using, and how they impact both of those features. Whether you spend less time and think about your the likely concentration, the number of people, the number of sources, the activities they're doing, all of those things play a role in your exposure and your risk. Thank you.